All right, everyone. Again, I don't know that we need to go all the way around the room with introductions, as Josh has been in front of us before. We can just kind of do the hand gestures, and please identify yourself should you have a question after Josh's presentation. Again, the one introduction, Josh, I will make on your behalf is Michael Walster, who joined our team out of the Erie office a number of months ago. And so he's been working closely with companies out of that market and all throughout our footprint since then. Josh, I'm going to allow for you to go ahead and do your pitch for about 10-15 minutes, and then we'll jump into Q&A similar to the past times that you've been in front of us for Pre-Seed and Techcelerator, and we'll go from there. So feel free to go ahead and share your slides and get it going.
Okay. All right. Can I confirm everyone sees them?
Yes.
Wonderful. So hello, everyone. It's been some time, but I hope you guys had a good Q4 and Q1 so far this year. My name is Joshua Rooker, for those of you that don't know, and I'm the CVO and principal of SnapHealth. I will mention that silently on this call, we also have Erica Hollingsworth and Aislinn Sutcliffe of my team. They're definitely here, I think, for emotional support. We'll see how that goes. But what I will say is that we're in a unique space. We're a team with over 10 years experience in health insurance, claims, billing. We have a brick and mortar in Lancaster County. And we're in a position now where we're building an application to basically duplicate what we do day in and day out with our clients. So before I dive in too deep, I wanted to mention a pretty jarring statistic. In 2021, the US spent over $4 trillion on healthcare. As we talk about deficit and you know, large numbers, is definitely a cause for concern. That accounted for 18.8% of GDP in the United States. That number has grown since the beginning of the 2000s era, where it was closer to about 5%. So we're definitely spending a lot in treatment and care across the US. So the system is only, this system is the only one where you buy insurance on an asset before you buy the asset. And from the start, your insurer dictates where you can go, what you can do, and the cost, but they don't make it easy for you to find out any of that ahead of time. And they don't hold your hand to navigate along the way. So for a parallel, imagine buying car insurance, then going to a dealership, and the car you buy isn't covered, and you have to pay the full amount out of your pocket. And any issues you have along the way, you're stuck. It's your cost, you have to deal with it. Any other industry, that is the backwards way of managing anything else that we have going on. So in order to empower patients, you know, I spoke about a macro situation of GDP, but we really find that patients have been left out of the room when it comes to managing healthcare, when it comes to pricing procedures or disclosing agreements. And in order to empower patients to be the drivers of bringing that cost down, we identify 3 issues within the market. 1, there really isn't a central hub where all of your health history, insurance data, health technology, whether that's Fitbit or whatever, you know, Weight Watchers, any actual health related data pours into. And there's no place where it pours in and actually interacts with itself. You know, every time you're dealing with healthcare, you're going to disparate parts of a system to try and make a complete picture. Second, there's no proactive way to determine the costs or quality of care currently. Again, there are things that you can dig for, but they're not readily available to most consumers. And third, healthcare didn't come with a user's manual, right? When you work on your car, there's a maintenance manual. You know the most efficient way to fix any piece of that car based upon what the manual says. There really isn't an unbiased user's manual to this system. I'm not saying, forego medical treatment. I'm saying when it comes down to finding the right place to go to get a test done or to interact with the system, and how to dispute a claim when there is a problem, and how to deal with the billing department, there's not a real good user's manual. So here are a couple of examples. I won't dredge on this too far, but we've had a client that made an error in enrolling in a plan with Highmark Health Insurance Company, good company. He enrolled in a plan, made the wrong assumption about how to calculate his income. And we were able to look at look at his situation and save him about $700 a month in health insurance premium, which obviously $7,000 a year more than is a pretty big deal for the exact same plan, exact same deductible, co-insurance, and the like. SnapHealth would have caught that and would have advised them on how to properly account for their situation. The second one is a provider retired and another provider took over their practice, told the patient, we don't really like this medication, I more so prefer a different one. That raw cost without any insurance would be a $300 copay. Now, with insurance, he was supposed to pay $3, but CVS mentioned that he would actually have to pay $300. And had he not had our resources, he probably would have just paid it. Or worse yet, gone without the medication because he couldn't afford it. SnapHealth would have informed him that if the pharmacy says $300, it's probably because there's a prior authorization that's required, and would have been a steward to help him navigate that situation, tell him who to call within his insurance company, and how to notify the provider. And the last one is a pretty serious event where a patient had a baby. They were in the NICU, and they were in there for months, got released. 3 months later, they received a medical bill for $750,000. They should have, or the insurance company and the hospital stopped working together. So what should have happened is while the patient was in the hospital, there would have been a notification sent to the patient or the parents to let them know that there is a contract that ended and they're going to have to reach out in order to get the medical, the treatment covered by the health system. Ultimately, in our case, it took a year, power of attorney, and some serious legwork to try and get that claim covered with SnapHealth. The day that agreement ended and their system updated to say they're not participating, there would have been an alert that would have been sent out to the patient while they're still in the hospital so that they can proactively manage their healthcare. So what I'm looking at is nothing new. Over the last 10 years, if you look on the left-hand side, this is what our system's been. It's been silos of physician data, pharmacy data, insurer data, hospital data. Every system has had a proprietary method or secret sauce to build out organizing your information, which is why we go to a bunch of different places to get the full picture of our healthcare. That's not true anymore. There were laws that passed as early as this past January, only a few months ago, that make it required that the data is standardized into objects that should be machine readable across any system. And in addition to that, if a patient asks for it, the system has to release it to a third party like SnapHealth. So these new laws make it possible that the data that's coming in is clean, it's right, We're not worried about inefficiencies in bringing the data in. What we're doing, though, is we're adding an analytical layer of our experience to bring that data into one bite-sized piece that's actionable, with the hope that over time, consumers can use it to be better stewards to their own healthcare, and that there are other industries that would benefit from that aggregated data. So in its raw form, the data that's brought in, patient demographics, clinical notes, medications, itemized bills, active problems, past procedures, there's a lot of information that's going to come in that needs to go in specific buckets. On our end, those buckets are designed to help the patient improve their health. You get diagnosed with diabetes from a provider, and all of a sudden, when that hits our system, there's a notification that there's a local group of other individuals with diabetes that you could join as a community, or articles from the NIH on how to manage your blood sugar. You'd have a 360-degree view of your healthcare. You'd be able to control ultimately who has access to your record at any given time. That could include caregivers, that could include providers, that could include your broker that's applying for other insurance products for you. That could include your family if you're admitted to the hospital, disseminating a notice to them saying mom's in the hospital, and reach out to X, primary caregiver, which will be able to report on her status as she goes. Ways to advocate for the costs of care, and then just reports on the system that allow a patient to benchmark cost and quality. So to shift from that, I know we've talked a lot about what we're doing. Obviously, a car doesn't go without gas. And I think that's my last car pun today, so I apologize. But I do want to address how we're going to operate. So first and foremost, there is no cost for a consumer to use SnapHealth. That is a low friction point that we want to make sure as many people have access to the system as possible, without worrying about costs. So naturally, how do we get paid? The reality is we've been doing it for 10 years. As an insurance broker, behind the scenes, we get paid a percentage of every contract that comes through the door. So if a consumer is 64 and they're newly eligible for insurance for Medicare, or they are 63 and they're self-employed and they need individual health insurance, because the platform in essence is designed to help you navigate and benchmark, it's an easy transition to say that we're going to navigate and benchmark the full picture, which includes insurance. So our market's broken up into two categories. Blue is going to represent people 65 and older, and orange is going to represent people under age 65. In addition to that, you'll see in this matrix on the left-hand side, IEP and SEP are people that enroll year-round. IEP are specifically people turning 65. That happens 12 months of the year. And SEP are people that have a special enrollment period where they get married, get divorced, have a life event that makes them eligible for coverage. AEP on the right-hand side is people that are already enrolled in Medicare, but annually through that annual enrollment period are eligible to make changes to their plan. And OEP is the same for under 65. So if we're benchmarking insurance for these different people, we have the ability to receive revenue from multiple sources. We don't include SEP in our projections because we don't necessarily know that having a baby or getting married means that they need individual coverage outside of an employer. We consider that icing on the cake revenue. So by line, for Medicare, we get paid about $600 per year for a Medicaid beneficiary, whether it's Medicare Supplement or Medicare Advantage. We tend to make about $600 a year per person that's enrolled. Under age 65, we get paid $20 per member per month. So if I consider a household of 4, that would be $80 per month for that household in revenue that's paid already. It's already baked into the premium of the insurance that's on the market. Our job is to offer all of the options so that there are no conflicts, but ultimately it's the consumer's choice. Our job is to nudge them based upon how they actually interact with healthcare, not based upon contracted rates. We do charge an application fee. And again, not included on our projections, but if people purchase dental insurance, vision, life insurance, whatever, we do get paid for that. So for 2023, our numbers are, these are relatively conservative, 10 basis points of the market. And the way that each year works is that we get paid in 2023, we get paid 2022's Q4. Any enrollments that we do in Q4 of 2022 get paid out over the year in 2023. And then the other income that comes in 2023 is people that are new to Medicare. So that's a smaller piece of our puzzle. I'm not going to bore you on this, but what I will say, with all the different pieces that are listed here, we're not trying to boil the ocean. We understand that we're going to start in Pennsylvania. We're going to add other states, eventually be national. We're not going to roll out products before we're ready for them. We're very concerned about security, which is that bottom column or bottom row rather. And we're very concerned about making sure that really from now to revenue positive, that we're able to offer a valuable resource to the community. So competitor landscape, I do want to dive into this just a little bit. I know last time when we talked in the fall, there are a lot of people out there trying to aggregate data because this is a very public law that was passed. The reality is though, each platform that we've vetted over the last year have tried to be one of the black arrows. They're looking at a part of the problem, trying to provide provider-insurer solutions, provider-patient solutions, insurer-patient solutions. The only thing that's come close has provided aggregated data to the patients, but they're not adding that analytical piece of it. So as far as our team is concerned, like I said, we've been doing this for 10 years. Where we don't have areas of expertise, we bring in Andy Long and Joe Hackett exclusively. No, we have a lot of different people from a lot of different backgrounds that give us support in legal and EHR and tech and business growth. Just to give you a little bit of background, obviously, because we do understand that the team is as important as the idea, is my background is not in healthcare. Like that wasn't my end goal. My goal was to be a mechanical engineer, and then the economy tanked in 2007, and I took that experience and applied it to financial planning until my son was born in 2013, where we got double billed for that event. And over the last several years, we've added a health insurance agency to help other people navigate the system. We started R&D on SnapHealth in 2018 while these new laws were coming about. And we've even started a nonprofit in 2020 when COVID hit and a lot of people needed help. So this is something that has been in the works for a very long time. Over the last several years, our team has grown and we've all had our own experiences. So it's not just from a client side, but also from a personal perspective. We've seen a lot of these things happen. And because of that, because of our knowledge in the industry, we do have contacts within the Department of Health, Penny at the state level. I've written for Kaiser Family Foundation as well. And we're in a lot of different trade groups and government working groups. To that point, the law that I'm talking about that becomes, that makes this all possible, I was in the room in DC in January of 2020, right before COVID hit. The rule was still a proposed rule. And I was in that meeting with the Department of Health in DC talking about how that would be implemented. So we're very intimately involved with the market. Now, briefly, you guys put your faith in us in the fall. You gave us a grant for $10,000, and I'm incredibly appreciative of that. We folded that back into the organization between UI and UX and development, brand identity, as well as filing for trademark and managing our business. We've taken away this complex idea to say we're a patient hub for patients with a user's manual component, concise ability to explain what we're trying to do. We have a brand identity now, and we're in the process of building our voice. So our next ask is for a $150,000 tranche. We are looking to raise about 450,000. I think I have it at 465, specifically to get us from once our MVP goes live this fall to revenue positive in Q2 of 2023. Because again, if you remember, everything that we do in Q4 of this year will be paid out to us Q1 through Q4 of 2023. So we really need to bridge that gap, and that's where we're asking for help. In the interim, with that money, we're looking to hire 5 people in Pennsylvania that we will use for ops and for customer service. So I know I'm over my time, but ultimately, I think it's very important that you guys understand why we're doing this, where we're coming from, and how we're going to make it happen. So thank you.
Thanks, Josh. Go ahead and pull the slides down if you would.
Absolutely.
And I'll open things up to questions to our group. Out of the gate, just turning to State College, any questions to you guys up in the State College office?
Yes, hi. Thanks, nice presentation. I appreciate that. Andy, thank you. This is Sherry Davidson. Hey, so as you mentioned in your PowerPoint that we are currently in a pre-seed with you. So I was wondering, what is the status of that then? Are we close to completion or it's in progress? Where would we be right now with that original pre-seed project?
Did Josh drop?
I think he dropped and
He's coming back in.
one way to take your slides down.
Gotcha. Okay.
He's coming.
Okay,
There he is.
there we go.
Uh-oh.
Hey, Josh. Sorry about that. Hey, hi, Josh.
Hi.
It's, Sherry Davidson. Hi, nice to see you. Nice presentation.
Thank you.
We're here at University Park. So Josh, thanks. We learned a lot. I just was wondering, I know you referenced the pre-seed. So where are you with the pre-seed project? I know what the use of funds are, but is it close to completion with the pre-seed?
Can you repeat that?
Sure. Are you close to completion with the pre-seed? I know you gave us an update and said you're working on that, but have you completed the pre-seed this time?
So parts of it. So what we did is we signed a contract for $26,000 with Thread, which is what the pre-seed was designed for. Unfortunately, the lead designer with Thread, his father passed away in January. So that set us back a little bit. That being said, it is a 3-part project. The first one is building out the brand and identity. The second one is they're doing all the front end UI and UX design so that we can hand that off to a developer on the back end. And then the third piece is building a landing website for people to sign up for beta. And at this point, we have completed the initial brand and identity design as far as having our voice and our tone built out. We have a 26-page report from Thread that has given the direction of where we're going. Right now, they're building the creatives.
Okay. Thanks, Josh.
Yep.
So I did have a couple questions, kind of built around your balance sheet a little bit. So
Mhm.
I noticed that when we started, or when you ended the year 2021, there was a line of credit balance, and it looks like maybe, did you pay that off in this year? It didn't carry forward in 2022. So I
Yep,
was just wondering if is
I
that
did.
paid or just,
I did pay that off, and that's why you also see partner contributions ticks up from Q1 or Q4 to Q1.
okay, great. And when I'm checking things out, I noticed there's convertible note investors 2-year deferred. So $150,000 drops onto the balance sheet as a long-term convertible note in third quarter. So what does that build around?
Right.
Is
So
that us?
nope. No.
Okay,
So Ben Franklin is listed separately, and I worked with Jennifer to make sure that those numbers are right, both from an accumulation and from a payoff perspective. The other side of that is looking at private equity within the current contacts that we've had discussions with. So we would be looking for funding that would ultimately have a 2-year deferral before payments would resume.
okay. So that's to be determined. You're hopeful that will happen and okay, the deferral was what had me a little confused there. So thanks for that.
Yep.
And then I noticed the other question is just the contract assets with the commissions receivable. In the fourth quarter of 2022, we're bouncing up to the 1.1 million with receivables. Is that, could you just talk about that just a little bit?
Yeah, so annual enrollment period is anyone that's already over 65. Those people between October 15th and December 7th, they reevaluate their insurance. And if they make a change, then the broker that is listed as a broker of record is compensated for that change. We are actually assuming 50% of people will make a change, and a 5 basis point injection into that market. So really 2.5 basis points of acquisition in Pennsylvania. And then the other one is the open enrollment period, which is currently 14.5 million people across the US. In PA, it's about 380,000 people. Those people tend to change more often. We had 2 years ago in our county, we went from 35 plans to 95 plans. So each year that market is looking at changes. And the reality is, even if all we did was market to our county, there are 17 million people that are in that market. And we're looking at a total acquisition of about 1,500. So what happens is you'll see in the balance sheet a bump for Q1. That bump in Q1 is because all the AEP compensation is paid out as a lump sum in the first quarter of the following year. And the OEP compensation that we have is paid out per month over the year.
Okay, great. Thank you. That's easy to follow. I appreciate that.
Yes, ma'am.
The one other question I had, Josh, and that is just regarding the development of the software. So I would be expecting to see your product as an asset, some kind of either software development that's being accumulated, depreciation over some time, but I'm not viewing that in your asset list anywhere. So is that just not, if it's an oversight, that's okay, but the development of your software, okay.
Yeah, I would say it's definitely an oversight. On my end, we've run pre-money valuations with before and after the $50,000 injection that I did at the end of Q4 of 2021. And we've also run pre-money valuations before and after that MVP is live. That's really the extent of determining the value of the platform. But as far as depreciating and accounting for the intellectual property, I don't think that was a topic that we talked through with Jennifer. It's definitely something that we would like to include. It would just take more due diligence to get the right numbers on there as conservative as possible.
Okay, great. No, that's good stuff. Thank you so much for the additional information. Anyone else here in the room?
Sure, I'll ask and maybe just don't understand, but is there a connection between your existing business and what SnapHealth is doing? You were referencing often your experience, in the industry at this point. And is this a spin-off from that, or is there any relationship or connection between the two?
When you say connection, can you be more specific?
Well, is this a product that is being developed underneath that existing business that you're going to market through that business or through your customer base from that business?
So potentially we would be looking at using our initial client base to be a test pool, just because we've had some of those clients since 2013. And as far as my position, what I do see is that there are trade groups that I'm a part of where the relationships that I have with brokers on a first name basis, they manage about 50,000 consumer relationships that we would also be looking to beta test. And we're not looking to step on their toes, because oftentimes these are brokers that deal in the large group market, where our platform would help fill out the individual market or the Medicare market, and they're not looking to touch that anyways. But it's not something that is being built under PA Health Advocates. We've gotten some information from Ben about the importance of separation of church and state, right? To some degree, we need to keep those things separate. But we also recognize that having a dedicated team on both sides, our agency has been the piece that's been funding SnapHealth up until now, and that's where those contributions are coming from. I'm sole owner of that agency, so there aren't conflicts of interest of other partners that would be an issue, if that makes sense.
So then, Josh, just to take that back then, so the asset or the licensing, is that in your other business? Is that in the other company?
What licensing are you speaking of?
Well, when you said you were developing the product and developing, are you licensing it between the two, or this is a wholly owned?
Wholly owned
assets
under
of the company.
SnapHealth. Wholly owned under
Okay.
SnapHealth. Yep.
Okay. Very good. Thank you.
Yes, ma'am.
Anyone else? All right.
Sure.
Thanks. Thanks for the info, Josh.
Thanks.
Thanks, State College. Anyone else from the group have questions for Josh and SnapHealth?
Hey, Josh, Mike Walster here. I see you're going for a SOC 2 type 2, and it looks like maybe NIST 853 at the same time. Is that right?
So we're prioritizing SOC 2 first, but they're going to be in our initial goal. Ultimately, it comes down to the fact that when it comes to patient data, especially when it comes to healthcare, it's very important that they feel secure. It's not a requirement. So SOC 2 is not a requirement for the systems that we're integrating with. It is purely to say, at the end of the day, that is a compliance requirement for the IRS. And if we are meeting what is a security and compliance requirement of the IRS, then we're meeting our fiduciary duty of care.
Right.
Now, NIST, eventually, when it comes to us integrating with other systems, there are systems that require that NIST piece of it. So they're not going to be done at this concurrently, but they are in that initial rollout, what we're looking for.
Yeah, so something to think about. There's a lot of overlap between 853 and SOC 2 type 2. So depending on your auditor, you may be able to get 1.5 birds for one stone. I've got a crosswalk that compares the two and aligns NIST with SOC 2 and cross-references the requirements. If you want me to send that to you through Andy, be happy to do so.
Absolutely. Yeah, I would take anything. Thank you.
Yep.
Thanks, Michael. Appreciate that.
Mhm.
Anyone else from the group have a question for Josh? Eastgate.
So I have no idea what Michael and Josh just were talking about. At some point, I would love to get my arms around it. So the fundamental sort of business concept is that you are creating a platform that is attractive to consumers, and you're then providing insurance solutions that they'll enroll through this platform, and you get paid by selling that insurance. Is that essentially the revenue model?
That is the revenue model for version 1. And the fact that we can get consumers on there, there's going to be a mix of those that buy insurance and a mix of those that don't. That data then becomes a pool that if we can aggregate it and offer it to other systems, so whether that is clinical researchers or potentially there are insurance companies that require medical records data to make underwriting decisions. We've identified about 8 different ways to generate revenue, but version 1, again, not trying to boil the ocean here. That is our initial revenue model to go to market.
And how much patient data do you think you have to have before that starts to become compelling for people to utilize?
It's not a matter of having enough patient data. It's a matter of us having the infrastructure to share it, which I think is going to be the bigger piece. So for instance, right now, if you buy life insurance, you may have to get an attending physician statement that gets sent to a medical records department at a hospital that takes 6 weeks to get and costs over $100. If the patient is the one releasing the data, there's no HIPAA compliance issues. It could be immediately done and we determine the cost. But until we have that infrastructure in place, we're not going to roll it out as a marketable product. So I don't think the aggregated data is necessarily something that we're running towards, but there are ways to implement existing markets in a more efficient manner that will be incredibly attractive to adopters of our system.
Okay. And just pivoting a little bit onto the income statement. So between the fourth quarter and the first quarter, there's like a 10x change between 22 and 23. I'm assuming that's because the fourth quarter was open enrollment and you're getting a punch of revenue hitting in the first quarter from all that activity. Is that right?
Yep, that is correct. And that's also
Okay.
that's also the reason, if you look at the receivables for 2024 on the balance sheet end, you'll see a huge jump in receivables because of the fact that we're now accounting for our rollout to the US during Q4 of 2024 that we haven't been paid on yet because that starts in Q1 of 2025.
Got it. Anybody else here?
Hey, Josh, Steve here in Harrisburg. And maybe this is a question for you or for Andy. Generally for us, when we do a pre-seed investment in a company, it's really to answer some specific questions that allow us and you together to be smarter when we get to kind of the next phase of investment of your resources and ours. Can you help me understand how are we smarter at the moment, and what do we know? What were the kind of results of that allow us to kind of move forward with more confidence?
And you're speaking specifically to the grant, is that correct?
Yeah.
Okay, so on the grant end, one of the things that we were dealing with when we requested the grant is that this is not a concise issue, right? It's a very complex issue. And not only that, identifying how to get it out to market effectively and make sure that people are confident in what we're doing. We're trying to build a layperson system. So a lot of the industry that I've been in, unfortunately, becomes explaining a complex issue and unpacking and unpacking and unpacking. And what I took away from with the grant is really going down not only the unpacking with Thread, but also their their resources regarding the market needs to be able to unpack it and make it digestible. Because the problem is I can sit here all day in these meetings and explain it over and over and over again. But at some point, that also needs to be delegated to clear, concise messaging and clear, concise vision that Thread has helped us with.
Okay. Yeah, I do understand the complexity issue. Obviously, this is why there are brokers, and that it hasn't been a simple transaction. Okay. You guys, other questions here? We're okay at Eastgate. Thanks.
All right. Thanks, guys. Any other questions for Josh? All right. I am not seeing any. Josh, if I could ask you and Erica and Aislinn just to kind of drop off, I will be back in touch with you once our team has a chance to wrap with one another about next steps. And I'll be in touch shortly.
All right, wonderful. Thank you, everyone.
Yep. Thanks again, Josh.
Bye.
Josh.